Okay. Good morning. Welcome everyone to our Pediatric Grand Rounds. This is our OFD Grand Rounds brought to you by the Office of Faculty Development. My name is Marin Luno. I'm part of the Office of Faculty Development, and I'm honored to be here today to introduce our speaker. Dr. Syed is the Clinical Director for Adolescent and Young Adult Health. She completed her fellowship in General Academic Pediatrics and Adolescent Medicine here at the Children's Hospital of Pittsburgh, where she also began her interest in physician wellness. A term not fully developed at the time, Dr. Syed was an advocate for resident work hour restrictions and recognized the need for balance in the lives of physicians. Prominent mentors in her life included Drs. Bogan, Reese, Moss, Feldman, and Murray, as well as the late Dr. Hofkosh. They all illustrated the various ways of achieving balance in life that Dr. Syed astutely observed. As clinical director, Dr. Syed takes pride and care in researching techniques and workflows to help her colleagues. She is a member of the Children's Hospital Wellbeing Task Force and attends the Physician Thrive Wellbeing Symposium annually to keep up on the latest regarding physician wellness. In addition, Dr. Syed, along with Dr. Giddies, heads up our biweekly wellness presentations in AYA to promote a culture of wellness. As our speaker for the Office of Faculty Development Lecture Series, Dr. Syed is here to present her work on helping us get our charts done so we can get home on time. This is work she developed for her capstone project for the UPMC Physician Leadership Essentials course. Please join me in welcoming her for her presentation entitled Charting Wellness and Wellness in Charting, How a Refined Soap, Lizard Training, and Ohio Dreams Can Help You. Welcome.
Hey, thank you so much, Marin, for that kind introduction. I'm going to stand over here because I get swallowed up by the monitors. It's truly an honor to be presenting at the Children's Hospital of Pittsburgh Grand Rounds. This is probably going to be one of the highlights of my entire career, being up here presenting to you. You might have wondered why an adolescent medicine physician is presenting on this topic. And it really just stems from my passion in overall physician wellness. I've had experience with generational and personal physician burnout. This over here. Okay. So I'm just to start with a little pathway of my life. My parents came to the United States in 1970 as brand new doctors from India. They were immigrants here to answer the call to fill the severe physician shortage at the time due to the tipping point of the effect of several wars and the impact it had on the medical field. I saw them work very intense, long hours that compromised many aspects of their health, from sleep to mental health, physical health, to name a few, and things that were mostly laughed about to cope and considered more of a badge of honor. One of the primary care pediatricians that I knew at the time during medical school said that he would come home and play the beached whale. So he would work very long hours and come home and play that while his kids would just play on top of them, on top of him. So this is what I knew by the time I graduated from medical school, to kind of tough it out and laugh about it and keep moving on. But as a bright-eyed new doctor for myself, I had no idea that I was heading on the same burnout path. The symptoms and diagnosis not yet known. But lucky for me, after residency, things did begin to change. The biggest ones I thought that had the most impact were the regulation on resident work hours, the development of hospital medicine, so we didn't have to work 24 hours. You had people to cover your patients at nighttime. And gradually an awareness of the concept of physician wellness. It was a windy road, but I was fortunate enough, so fortunate, to land back home in Pittsburgh, where I became the clinical director for adolescent and young adult health, where I saw an untapped area to advance physician wellness. This talk is dedicated to one of my several amazing administrators working in the background, being a bridge for patients who really needed to see patients in AYA. In the days of paper charts and messages, when she would see my empty shelf, this is what she would say to me: Dr. Syed, you are functioning. And I love that feeling, and I also loved her. So I do say that to myself when I see my inbox and everything is kind of almost down to zero, that I feel like I am functioning. With that background, we reach the goals of my talk, which are really of transformation. Physician behavior is one of the hardest to change. Let's just face facts. As physicians, we're pretty stubborn, and we like to do things our way. And after training, you think about after residency, and if you decide to go into fellowship, your ways are pretty set and rigid on how this is how we do things. We do things this way and this way only, and we're going to continue to do this for the rest of our lives. Even when I came here, like I trained at St. Chris, and when I came back, I was like, oh, this is weird. Like this was the St. Chris way, and this is the children's way. And we get kind of rigid about that. So for those of you who are looking for change, I hope to provide some practical strategies. For those who are not ready to change, or maybe are kind of thinking your path is still the best way, although it's not getting you the results that you want, I hope to provide some internal motivation for moving toward change. And for those who are efficient and satisfied with their work-home balance, I hope to encourage you to continue adapting to the changes that we need to avoid burnout. So on your phone, if you could go to menti.com for a survey question. In my work with physician wellness, I learned that it helps to start from a place of positivity. I hope this will work here. Is everyone able to see that? Can you see the question? Oh, okay, good. Okay, so you can go ahead and I'm going to move this over here so we can see. I can put that back up here. It is 7162-8126. Oh gosh, I'm not sure how to make it a full screen. Thanks, Mary. So it really helps to start from a place of positivity. I personally wanted to be a pediatrician to help children feel better and in turn help their families improve. And new results. Nothing's happening. Sorry. Might need some help. Oh God. Ooh. Here. What's up? Present. Oh, got it. That's better. Here we go. All right, awesome. All right, so here's your why. So it's, I love, sorry. Yeah, I love to hear these. Just especially the ones I'm not a good surgeon. And just and we're all having the biggest ones are here are just like helping others, loving children, happiness, adults suck, and empathy. That's another kind of thing we're gonna touch upon too. Okay, so let me move this back here. Okay. So just so we're on the same page, I know we started on that place of positivity. We just have to just look at this for just 1 second, is that physician burnout, we know, has 3 components. I'm not going to dwell on this too much because we've heard so many talks on this, but the components of emotional exhaustion, depersonalization, and a reduced sense of accomplishment. And over the past several years, we can see having at least one of these symptoms have been fairly consistent. In the days before EHR, electronic health record, I knew a lot of you guys, younger people, have no idea what this is. This is a paper chart. This is a chart of like loose papers stuck in a gigantic manila folder that would travel all throughout the hospital. If your chart happened to not be there, good luck. You would get a blank piece of paper. But in the days before, this is what I would frequently walk into and leave with and dream about and the day in and day out since I graduated from fellowship. So I've been a clinician living my dream of seeing patients. Over the years, I've worked between 3 and 8 clinical sessions, seeing sometimes unlimited patient appointments. But the aspect of charting quickly became the biggest drag of my professional life and of many others. I realize this is a little bit dated. This is a report from 2018, but this lists the causes of burnout. And while we've made, several changes with resident work hours and this and the things that I mentioned, I mean, to me, a lot of these things have to do with charting and just the drag that it places upon our life. So I just think a lot of these points here, we can make the case of majority of them being related to charting. So we think about how to significantly affect our wellness. Getting our charting under control seems to be the biggest bang for our buck. So compared to the physical picture of charts that I showed you, one benefit, so to speak, to the EHR is that we don't see that. But what we see is that tiny number at the bottom. Yeah, this is from one of my former resident colleagues who's a pediatrician. We trained together, and we kind of gripe about this and like agonize over this. And she was gracious to share this with me. This was only maybe like a month ago. It's very draining and it's very tough for us. But having the EHR, it has its pluses and minuses for sure. I mean, I think, this thing came along, we're like, oh, great, we're all going to be on time, our homework is going to be done. But the fact of the matter is burnout is still very significant despite having the electronic medical record. And you can see here for pediatricians, it still represents a very significant portion. This is another study from 2020, and talking about the question, the EHR adds to my daily frustration. And you can see those who agree, who are not burned out, those who agree, who are not burned out in the first column there. So that's the red, 56% would agree with this statement. But those who are burned out, that's the second column, 88% will say that EHR adds to their daily frustration. So there's a correlation there. But we know, reverting back to paper, it is not an option. And there's also some overestimating happening too. So people say, I have hours and hours and hours of work to do. I'm like, okay, well, is it really that? But at the end of the day, the EHR does increase our end user satisfaction and it does decrease frustration. So there are very good things about it. It's just how do we develop that concept, how to incorporate it? This is another just kind of like funny thing that I saw. The EHR, so we interact with this. So this is our day, is the EHR. And I thought this analysis captured one aspect as to why we might struggle with this system itself. Compared to the other things that we use, the EHR has the lowest score in terms of usability. So we need to give ourselves a break. We need to give ourselves grace and find out how we can really fit this into our present day. And those of you who have preteens or teenagers, I hope you know what that little red guy is on the bottom. That is our suspect. And if you don't know, you're gonna have to Google it and find out. Because as you can see, Google's very easy to use. Okay. When I became clinical director, one of the first confusions I had, after many, many confusions, was the long list of patient names and the title of which was referred to as the Ewok. Okay. But as a Star Wars fan, obviously my mind went to these like furry creature from the planet of Endor, but it is not. I quickly learned that the K was actually a C. So it is encounters without charges. These are the lists and lists and lists of our unclosed charts that appear on a list one day. So it's not just in your inbox. It comes to the big general gigantic inbox. And it is a very big problem. It's a very big problem because the consequences are significant. We can't process bills. There are significant errors that happen that cannot be corrected because the chart is not closed. When patients call for information and the chart is not closed, we cannot access the patient information. There's a higher chance of medical errors when you wait for a day, a week, 2 weeks, who knows, to finish your chart. The chance of the omitting important information is very high, and also a chance of never being done. And it really is truly the leading source of our burnout, and of course has personal financial implications. With those of you who haven't graduated yet, the concept of an RVU and so forth, it contributes to this as well. Okay, just a little bit of history and the purposes of charting. The purpose was just so we could remember. We could remember what we did. And as we gradually started seeing more and more patients, we needed a way of remembering what we did. So that we saw them again or someone else saw them, we could continue and pick it up from there. And this evolved into the SOAP note, okay? The SOAP note, we're all familiar with this. And what it is, it takes a problem-oriented approach to patient care and documents that in a chronological way as we see the patient. But the SOAP note came under attack when third-party payers entered the scene with multiple permutations of elements that we needed to document. Certain number of review of systems, certain number of history, this, that, like all these kinds of things to justify the billing that we finally, at the end of all that, were able to enter. With the development of rapid computerization in 2009, the Health Information Technology for Economic and Clinical Healthcare Act, fondly known as the HITECH Act for short, provided $27 billion of federal incentives to encourage the adoption of EHRs with the intent to improve healthcare quality, outcomes, and efficiency. So truly, honestly, with the bottom line of, where's our reimbursement? We can't do it unless the chart is closed. So I wanted you to know this kind of background. And we know the EHR is here to stay. So back to Menti, and hopefully be able to do this a little bit more seamlessly. And you're gonna type in the code 71628126. But it can't be that bad. It cannot be that bad. Things are never that bad, right? So I'd like to know, what are the advantages of EHR for you? What are the advantages? We can sit here and talk all about the negatives, but let's talk about the positives because we need to capitalize on that when we talk about charting wellness. I love this. Absolutely. I think the biggest thing is being able to read. You know, it is like really a doctor, the worse your handwriting is, the better you are. And this is great. Yeah, most data that's in one spot, much better communication, the safety, it's available everywhere. Lots of thumbs up coming through, saving lives, because we have our allergies there up to date. You can quickly review many patients at a time, absolutely. And wow, lots and lots of thumbs up. This is very fascinating. I love that. Okay, so back to our talk. Okay. Oops, what'd I do? Okay. So the EHR, we're seeing a patient, the charting, et cetera. Now we got to put in a bill. And really this is kind of at the end of the day, what is really boils down to us seeing our patients and getting paid is CMS has helped us. I know CMS may not feel like it's negative, but CMS has helped us by reducing our E&M coding requirements, boiling it down to the level of service to be medical decision making. So before we had to have like different components of certain number of review systems, physical exam components, blah, blah, blah. Now it really is boiled down to what did you do with this patient and why? And that's great for us because that's actually what we want to say. That's what we're writing. So our medical decision making is the main thing. And all of the other aspects are for us, for the healthcare provider and for meaningful use compliance. We won't get into that, but that's an also very important part. All right. The SOAP note, back to the SOAP note. The SOAP note originated, like I mentioned, from the problem-oriented medical record. So treating things from a problem-oriented approach. It was developed nearly 50 years ago, before electronic medical records by Dr. Lawrence Weed. It was initially developed for physicians to allow them to approach complex patients with multiple problems in a highly organized way. So today it is widely adopted as a communication tool between interdisciplinary healthcare providers as a way to document a patient's progress. My challenge, however, with the SOAP note is that it leaves a lot of homework. If you have just your subjective, objective assessment plan, that's just what you've done in the patient room, but then there's a lot of homework afterward. So back in the day, it was not uncommon that I would learn about urine specimens that were sitting back in the lab because the STI orders were never placed, or a message from a patient complaining that an antibiotic that was discussed was not at the pharmacy. And with most EHRs, the bill that was not placed prevented the chart from being closed. But I realized with Cerner, you can do that separately. With Cerner, you can put in your bill, but you can leave your chart open. I was there. I used to use Cerner. I know. But with Bridges Epic, we're not going to be able to do that. You need to have everything closed. So as a part of my capstone project, a UPMC Leadership Essentials course, I rebranded the SOAP note to fit my needs. And you are more than welcome to use this because this is just what we know, like SOAP note, that's like ingrained in us. But revamp it so that for your own specialty and subspecialty, so that you can close your charts as well. So what I did is the S, rather than being subjective, I change it to basically my medical decision making. So my specific information, the history, my medical decision making. So that's all basically my note. And then O is going to be my orders. So when I'm telling a patient, yeah, gosh, you've been bleeding a lot. Let's make sure we're going to get a CBC. We're going to get a von Willebrand screen. As I'm saying it, I can put it right in as I'm saying it. So that way I think of it in this way. So my orders are done. And at that time, I usually will peruse the med list and fix it and update it and clean it up from there. And then as I'm saying like, oh, okay, you're here, primary dysmenorrhea, whatever, this, that, and then I just put in my billable diagnosis. If you're not sure what a billable diagnosis is, also something to investigate with your leadership, that making sure that you're not putting counseling codes, you're not putting in diagnostic codes that you're not going to get reimbursed. It's important to make sure that you're getting something that you will get paid for. And accurate E&M codes as well. And then I put in my charge. I put the bill in and that's it. Goodbye. I close the chart. It can be hard to let go of that. I realize that this is our masterpiece. And it's hard to just say goodbye so quickly and move on to the next one. But once you kind of get used to that, it's not too bad. So this is my updated SOAP note. There's not as much in the literature on charting and charting wellness, but primarily most of that comes from the world of family medicine, which is not surprising. And one of the things that they really talk about is the concept of charting as you go. And it sounds simplistic, but also can seem very overwhelming. But combined with a SOAP note that fits your life, it can really minimize your homework and be a game changer. I'm personally like an 80-20 kind of person. So for me, 80% of my charts being closed or 80% of the chart being done, that's acceptable. And then I'll have 20% of homework to do. But since I've been practicing these methods, I'm closer to like 5% or 0. I mean, walking out of clinic with everything done, and things are basically free for the evenings and weekends. So this concept of charting as you go is you just make the whole thing part of the visit. Don't separate it out. That's what we've been trained to do with our traditional SOAP note. So as you see the patient or immediately after or while you're doing it, you just finish all of it. And then you keep your homework to a minimum. Oops, keep doing that. All right. So this can allow you then to be fully present for each patient. We'll talk about that in a second. Let me just make sure I didn't. Yes, okay. So being fully present for each patient, having less interruptions. So when you've already put in your things, if people aren't going to be interrupting you to do it, you have much more brain energy to focus and see your patient, improve patient satisfaction. They feel that you're there actually listening to them. And just better communication and then more time to do what you feel that you want to do. All right. So how are we doing in AYA? I've been promoting the method of SOAP note and charting as you go. And this is a little bit more kind of updated data. And if you see here going counterclockwise, this is the 100%. So the question is, what percentage of the time are your charts closed before leaving for the day? And 22%, 100, but 75% it's past the 50% mark, which I think is pretty awesome. And if we look at confidence importance, how confident are you in closing your chart by the end of each session? Also past the 50% mark here. And then how important is it for you to close your chart? And we can see it's almost close to 75%, which I think is great. Of course, we can't be perfect. So this is good. All right. So one of the things, okay. So an example, how do we incorporate SOAP? How do we incorporate charting as you go? And here's some suggestions on how to do that. I'm basically setting yourself up for success. That's what we want at the end of the day. So preparing, either having a quick huddle with your MAs. What I like to do is I look at my chief complaint and what I just put in the encounter comments. Do I need a urine, a PHQ-9 or whatever? Sometimes I go into the room as the patient is being roomed so the MA, you don't have to repeat everything. I hear the chief complaint and I start typing. I bring my laptop in. I organize the room so that I can have the computer facing them and don't have my back to them. And I really truly try to share the medical visit. I mean, they can see it. They're going to be able to see it anyway. But when I'm reviewing the medical list, when I'm entering the orders, I show them like, okay, these are the things I'm doing. And sometimes they're like, oh, by the way, could we also do this? Sure, that sounds good. And then, placing all my diagnosis and closing the chart. Things that can help, obviously, customizing your EHR function. And there's a lot of that, right? Like dot phrases and all this kind of stuff. And you can go wild with that. But you may not need to. You can also copy forward. You can affirm things that haven't changed. And really, truly, if you haven't mastered touch typing, which I think most of us have, using dictation is also, scribes are also a technique. And then, of course, AI. And we're going to have someone telling us about that as well. Okay, so yeah. Then our masterpiece will be done. I touched a little bit about, oh, sorry, wait. All right. So one of the other things that I hear about too is complaints about the amount of clicking we have to do in our day. So while we think about changing the mindsets for an up-to-date SOAP and charting as you go concepts, there are physical aspects to consider that can be very useful. So I have my colleague here, Dr. Drickman, who has this awesome mouse that has helped to reduce her carpal tunnel. Dr. West, who uses a scribe to help him to keep up to date and helps his hand not avoid carpal tunnel. And my colleague there, Dr. Waters, who has a portable desk to go into rooms that also increases efficiency. And so yeah, how many clicks is healthy? The world may never know if you don't know this analogy. This is like a Tootsie Pop. So the little owl would like, look, how many licks does it take to get to the middle of a Tootsie Pop? And after 3, he just crunches it. He's like, the world may never know. But yeah, we really want to protect ourselves. We're going to be able to work a very long time as pediatricians, hopefully. So we want to make sure that we protect ourselves physically too. All right. This is a real chief complaint. I'm not kidding you. This is what I experience in adolescent medicine in my 30-minute visit slot, sometimes a double book. It can be very daunting. This actually is a real story. I finally embraced AI and went through all the steps needed to do it. And this patient came up, and this is the first time I was able to use AI, and it was like a world of difference. So we're going to have a mini presentation within a presentation from Katie Ahrensfield, who is the lead of provider informatics at UPMC. I went to the Physician Thrive conference last, and I heard her talk, and this is really what motivated me to adopt AI and use it. So, all right, so we're gonna have Katie, come on.
Thank you. Good morning, everyone. Can you hear me okay?
Yep.
Excellent. I am thrilled to have this opportunity to pop in, albeit remotely, to spotlight ambient AI here at UPMC. Like Dr. Syed said, my name's Katie Ahrensfield, and I am proud to lead the provider informatics team here at UPMC. And with me today, and really with you today, is my partner in crime, Mariana Steyer, who's been instrumental in the implementation of this tool, especially for our children's physicians and APPs. And I'd just like to also take a moment to acknowledge 3 of our exceptional leaders whose vision, whose advocacy has really been instrumental in advancing integrative technology here at UPMC. So Dr. Rob Bart, Dr. Mike Curran, Dr. Rupen Modi, among many other amazing physicians and leaders. We're truly fortunate to have such forward-thinking, dedicated champions supporting our physician and APP community. We would not be able to have this technology without their leadership. So I will get things started on our behalf. I'll kick it over to Mariana, and then both of us are really happy to answer any questions you may have, either in person with Mariana, or I'm happy to kind of have any one-to-one discussion. We can share our passions about ambient AI after our presentation today. So we'll make sure that all of our contact information is readily available for all of you. And we can go.
Next slide.
Oh, sorry, 1 second. We could stick to this slide. My screen just jumped. So, short overview of what we're talking about here when we're talking about AI. So you might have heard the words ambient AI. You might have heard different vendors. The vendor that we're moving forward with under Bridges is called Abridge. So Abridge, in short, is UPMC's ambient AI solution for physicians and advanced practice providers. So it converts clinical conversations into documentation, and it integrates directly with Epic. So it supports over 50 specialties, more than 28 languages, and it works across all care settings, including outpatient, inpatient, and emergency medicine. So we have just 3 slides to talk through today. This is the first, and this first slide really offers a peek at real objective data, a little case study from our EPIC signal database. We've done many of these, but this is the specific one that we were asked to spotlight today, coming out of our Thrive session last fall. So for those that may not be familiar with Signal, at a very high level, Signal is an EPIC hosted web-based application, and it provides a data-driven approach to measuring clinician efficiency and proficiency within EPIC. So Signal shows us how our physicians and APPs are using EPIC, and it compares to colleagues within the same specialty. And it also compares to the rest of the EPIC community, which is pretty cool. So you can easily identify areas where our physicians and APPs stand out. And it also helps us identify those areas for improvement. And as a provider informatics team, we are looking at this data every day, and we really leverage it to help us identify trends. So are physicians and APPs spending more time documenting versus other organizations? How can we help to optimize our instance of EPIC on a system level to help empower our physicians and APPs to document more efficiently? So it's really a powerful tool, really significant metrics. We could do a whole presentation on this topic alone, but all of this to say, using this sort of treasure chest of data, we looked at one specific physician from our central PA region, and 3 metrics really stood out from the defined period of February to May. So this is looking at after this physician's adoption of a bridge, ambient AI, this physician decreased the amount of time they were writing their progress notes, the first kind of shape on the left, from 64 minutes per day on average in February to 45 minutes per day in May. Outstanding. The middle little bubble here shows that this physician also decreased the amount of what EPIC calls pajama time, their little whimsical term for the amount of time that this physician was spending, quote, after hours, from over 140 minutes on average per day in February to just 36 minutes, and I say just very lightly, but 36 minutes per day on average in May. So a decrease in time on average of 2 hours. Amazing. A bonus metric to the right was a decrease in the amount of time that this physician was actually spending entering orders, which is not necessarily directly related to ambient AI. But after working with this physician one-on-one, it's reasonable to share that their decreased cognitive burden that they felt from the benefits of using this tool certainly helped to empower their journey to becoming even more efficient and proficient within EPIC. So there's, of course, many other possible external variables that contributed to these results, and it's really difficult to draw any hard and fast or certain conclusions other than our physicians are using this, they like it, and they're spending less time in EPIC because of it. And this is certainly a testament to our amazing team that we have here at UPMC. And we do believe it's reasonable to say that this is a testament to the innate benefits that ambient AI has to offer our physicians and APPs, which then leads to the discussion of subjective data on the next slide. And this slide right here, perfect. So here at UPMC, we approach this initiative, as Dr. Syed so eloquently explained in her opening, as a wellness initiative. So in order to get access, our physicians and APPs had to fill out a survey first. So we did baseline wellness surveying, and we continue to follow up at 1 month and 3 months use. And across the board, for all wellness related questions, our physician and APP community believes that their note quality is better, they've increased work satisfaction, they perceive that ambient AI has improved their workflow efficiency, and they would recommend the tool for use to their peers. So the longer they've used it, the stronger these data points have become. And that's pretty clear from a wellness standpoint. And the reduced cognitive burden for our physicians and APPs has really been incredible. Ambient workflows virtually eliminate the need to sit face-to-face with a computer screen in exchange for a high-quality face-to-face patient interaction. Our physicians, our APPs, burned out by administrative documentation requirements, as is the theme of today in talking about charting and wellness. And Ambient really empowers our physicians and APPs. It improves confidence and it reduces stress. So the quantifiable outcomes that we talked about in the last slide, they've been outstanding. However, we would argue that the seemingly immeasurable metrics, what you see on the screen here, the feedback that we receive every day from our physician community, that's really the true power and the true magic of Ambient AI for UPMC. And I really hope if you haven't already, you will give it a try. So moving into our last slide, I'll just make two final quick points and then I'll pass the mic to Mariana. So first and foremost, know that a bridge Ambient AI is coming for all of you. For our physicians and APPs, you will get it. And what's really exciting is that UPMC is working to prioritize and simplify this process for all of you. So we're working to eliminate any barriers, reduce the resistance to adopting this tool. So on day one of your Bridges Go Live, you will have access to this tool. And without getting into the nitty-gritty details of all of that, if you're unsure what this looks like, if you want to learn more about this tool, any specific questions, please reach out. We're happy to help you on your Ambient AI journey here at UPMC. I will make sure our contact info is in the chat as I pass the mic to Mariana. So thanks so much.
Thank you so much, Katie. Actually, just for the interest of time, I'm going to have Mariana stay afterward for questions because I have a little bit more information that I want to go through. One of the side effects of AI and also just with charting in general, copying, pasting, all this kind of stuff is this concept of note bloat. So I wanted to just bring this up as well. We have a limitless page to document, insert dot phrases, etc. So sometimes we run into the opposite purpose of the note to find information easily, and it makes it kind of worse. So at the end of the day, it is just a note. So here is so you can see kind of like visually the median length, the words increasing, the redundancy increasing, and so you want to really ask yourself in your note, are there redundancies? Am I using dot phrases just to fill? So sometimes we just think like the longer the note, the better it's going to be. Am I screening for inaccuracies when you're copying forward? And then is it going to be easy for a coder to kind of see? So right, at the end of the day, it is just a note. We want to really recognize that War and Peace has already been written. Okay, so we heard about charting as you go. We heard about AI. So what if I said by the end, we have like 10 minutes left. What if I said by the end of this, you had to change, period. End of story. By the end of this, when you walk out this door, charts have to be done. You can't with each and every patient. So what I want to know, just go to menti.com again and tell me, what are the thoughts that come to your mind when I say that to you? If any, unless you're already perfect and you're not doing this. So anyone have any thoughts? If I said you had to change, end of story. All right. So in the interest of time, I am just going to move forward because basically people may say, you have no idea what my life is like. I have a lot going on and that's an impossible task. It's ridiculous. And I'm already so overworked. Don't even ask me to do this as well. And this is the problem here, is that we have to kind of also look at things in stages of change. We have these really great opportunities in terms of AI, et cetera. But these are really thinking about stage-based strategies. For those who are, ready to make these changes, those things I presented are all going to be good for you. But those who are really not really at that point of being able to think about this overwhelming task of leaving with everything done, then you're in pre-contemplation, and we have to address that as well. So I wanted to just go through some ideas of getting a handle on charting stress when you're not in that state of mind just yet. So it is a stress response. Like we look at our schedule, we look at the number of patients, we think to ourselves like, no way, no how, and we either fight it, we're not going to do it, or we freeze and we get like that we physically can't do it, or we run away. We run away from it all. And it's important to understand the cognitive errors that hold you back. So I think of this in terms of like a lizard brain versus a wizard brain. And I just very super simplistic for the neurologists in the room, don't hate me, but the lizard brain is like that basic protection, and the wizard brain like reasoning, like what are the most likely outcomes? What are the best case scenarios? And working from that perspective. So here's just some examples, okay? So for example, your lizard brain may tell you, like, the note will be better if I finish it later. It's going to be better. But the wizard brain is really, the best note that you finish is now. That's going to be the most accurate. The lizard brain may say, I can write the perfect note later when I have time. But thinking to yourself, a done note is better than a perfect note. And you can always go back and addend. You can addend all you want. You can wake up at 3 a.m. and addend all you want, but your note will be done. A plus care plus A plus note, it's kind of a D plus life. Let's just face facts. Like if we really can't even get our laundry done, we need to make some changes. But A plus care, a B minus note, hey, now that is an A plus life. My note needs to prove the quality of care I gave. I mean, this is a very common thought, but my note documents highlights from the 15 minutes we spent and focuses on the main issues. So different ways of thinking. Think of, how these can really help to revolutionize how you think about your charting. Mind reading, we do this all the time. The patient will be mad if I'm late. I will be present for my patient when I finish the work of my previous patient, and that is a fact. Medicine is like this everywhere, so what does it even matter? Medicine is an ever-exciting and involving field. I wonder if I can update my routines to meet it. Feels different. Thinking about asking for help, your medical assistant, they'll just say no. It's not worth it. It's just easier if I do it myself. They might be excited, something to help us all leave clinic on time. Labeling, I'm a bad doctor. I have all these charts waiting, I'm a bad doctor. I'm disorganized. Come on now, I've made it this far with hard work and perseverance. This is just another challenge. Chances are I will figure out the best way for me using all my resources, of which there are many. The last one, should statements. I should be able to do this. If you find yourself saying should is a bad word. Think about it in these terms. Next time, I'm going to spend a few minutes prepping my encounter comments so the MAs can be more directed. And wow, this day threw me a curveball. Next time, I plan to use AI for a patient with these particular complaints. All right, so now that we've gone over some of these wizard and lizard kind of setting thoughts, I hope that's just like a little touch of that. I'm happy to discuss more of that. But how do we combine this all together? So setting the agenda, we have, when we have patients with multiple complaints, creating a complete list of concerns, estimating the time requirements, and then prioritizing. So sometimes what I'll say, of all the things that you mentioned, what is the most important for you to address today? It may or may not be in alignment what I feel is best, and I'm going to incorporate what I feel is best, but at least I'm able to check that off. And when it's appropriate, I want to make sure you get the best care we can deliver. So I don't want to rush through and miss something. When would you like to come back so we can discuss and get to the bottom of this? And then planning for follow-up and checking for understanding. Interruptions, the bane of our existence. So when we're really trying to go in a straight line, it's not uncommon. We're thrown to other paths. And use what you have available. When we go to Bridges Epic, I know we don't use this in Cerner, but in Epic, we have a dot system that can say, okay, a white dot, there's a doctor in the room. A red dot, I need something. A black dot, patient's gone. And figure out what is your method of communication with your colleagues. All right, so since we're in a teaching hospital, this talk would not be complete without discussing how to incorporate trainees in our charting wellness initiatives. And I would argue that the chart being done or closed, it's a relatively new concept. So skill and thus a skill for medical school graduates. Up until then, the attending wrote the note and the bill was based on that. Now we can combine efforts with residents and fellow notes to have a product we can submit for reimbursement and reduce dramatically the clicking and typing. That is if the trainee's note is done. We recognize all the same patterns and the need for perfection of the note, the striving for beauty in the note, and all of that is important as we are aware, but we are doing our trainees a disservice by not facilitating their growth during the training period so that when they are attendings, they're malleable to the changing times and ready to optimize their personal life with the salary, time, and knowledge as attending. So here are some quick tips. Huddling with them and so that they can be directed, especially they're going subspecialty to subspecialty, month by month, day by day, Z blocks, all this kind of stuff. Having that direction is crucial. And modeling charting wellness. So modeling that, hey, my note is done, my billing is, the orders, etc. And teaching as you go. Sometimes we feel like we need to teach like the entire lecture, like with each patient, and we know that sometimes that's not efficient. And then, charting as you go with them, using the SOAP note as you precept. And I use AI when I precept, actually. So when I have a trainee and they're with me and they're presenting the patient, I'll use AI. And it's so cool. It like captures what we're talking about with the patient, and I'm able to close it and move on. All right. So now that we're all done, I just have a couple more slides that I want to discuss. These are for people who are all done with everything, they're efficient and everything. And now we have to move on to the inbox, which is like our also a big source of distress. But using your note and your portal to advantage. If you haven't already, all your patients should really be on the portal. And involving your team. And this concept of eating the frog is that it's like the hardest thing that you perceive to be done. And doing it first, then everything else becomes easy. In addition, only handling it once. So if you keep going back to it over and over and over again, it's going to take that much longer and give you that much drain to your brain. So thinking about organizing your inbox and your emails so that you only do have to handle it one time. All right. And then lastly, this concept of the Pomodoro technique, which is if you do run into backlogs, having 25 minutes of working, a 5-minute break, 25 minutes of working, a 5-minute break. Just keep your mind fresh and going so that you don't feel like there's this endless list. All right. So I was going to do this tale of two clinics, but I don't have time. But basically what it is when it's Friday the 13th and you don't chart as you go, what happens to you is that you end up, we all are familiar with this, like you're late and your homework is, you have tons of homework and everything. Whereas if you do chart as you go, even if you're late, taking a few minutes in the room to close the chart is still able to help you be on time. And submitting your orders and scripts just in a timely fashion as you're seeing the patient, less interruptions later. So can you all see movement on this? Okay, so all of these almond shapes are all the things we have to do. These are all of the patients for the day. These are the orders. These are the labs, the bills, the inbox messages, someone, tapping on your, maybe personal stuff like your child texting you at home that they can't find XYZ. But what I want you to do is right now, focus on one. Focus on one and tell me what happens. What happens if you focus on one? Stops moving. So this is just an illustration of mindfulness. Charting as you go, doing one thing at a time, keeping yourself so that you're not overburdened with what's all happening in the future, what's all happening in the past. Focus on one thing at a time, and it'll get done. Lastly, just want to end on this. Some people may say, how can we have empathy? We're pediatricians. We're, children, infants, like we're like the model of empathy. And how can we do that with charting at the same time? I mean, We can't. It just interferes with our empathy. And this is, I don't know if you guys know this painting, but this was a scene, this was a painting that was done in the late 1800s or so, and 1887, entitled "A Doctor." And it's this picture that is frequently used today to show the qualities of a good doctor, of empathy. This doctor at the bedside, and there's no chart in this picture. He's caring for this patient, and this is the model. This is like the concept of what we've really like continued today. So what I did was I asked my niece, who is 8 years old, to draw me a picture of her latest doctor experience, her trip to the pediatrician, and draw me a picture of her experience. And this is what she drew for me. She loves her doctor. Okay, she loves her doctor. There's alpacas in the bottom, and there's like fish on the wall. But look, right in the middle is the doctor on her computer. I did not prompt her, I promise you. So I want just to say this to be reassured that we can't make the charting this like monster, rein it in. Don't make it a big, huge, gigantic thing. We have wonderful resources. Marianne is going to be here just to talk about AI if you have further questions. The concept of charting as you go, reorganize your SOAP note that fits your life, and don't have homework at the end of the day. Leave happy and go do awesome and fun things, because that will help us in the long run. So, all right, and that is it.